So I'm going to get started. So hi, everybody. We're really, 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 really happy that you're all here. So we are musculoskeletal radiologists, and we're excited to present to you a little bit about our fields. We feel that it's especially important for those of you who are in the first and second years of medical school, because a lot of times exposure to radiology doesn't happen until later. And we feel that we do a lot of fantastic things, and that the earlier you get to know about us, well, the more likely it is that you might choose our fantastic specialty. So I am Dr. Maurer. I'm a musculoskeletal radiologist at MedStar Georgetown University Hospital. I'm going to ask just a couple of things. Please make sure that you are muted. You're welcome to have your video either on or off during the presentations. And at the end, we're going to have a breakout session for meet and greets, to answer any questions, and also to sort of connect those who are interested with mentors. I'm going to have everyone introduce themselves, and then we're going to get started with our presentations. So I'm going to start with Dr. Faraji.
Hey, I'm Naveed Faraji. I'm a musculoskeletal radiologist in Cleveland, Ohio at University Hospitals, and I'm happy to be here today. Thanks for having me.
Thanks, Dr. Faraji. Dr. Hansford?
Hi, I'm Barry Hansford at Oregon Health Science University in Portland, Oregon here, MSK radiologist as well. I'm looking forward to this session very much. Thanks for stopping by.
I'm Dr. RJ Klecker. I am at University of South Alabama in Mobile, Alabama, and just really happy that all of you chose to join us tonight. So, and welcome.
Wonderful. So we're going to get started. I'm going to start by talking about radiography basics. Here we go. Okay. So what we're going to cover in the next few minutes will be topics that are very, very basic for all of radiography. So we're going to cover the 5 basic densities in X-rays. We're going to discuss the importance of orthogonal projections, and we're going to discuss the importance of high-quality images. And we're going to do this with a case format. So here we go. So first, let's understand a little bit about the 5 basic densities in radiography. Our first case is a 44-year-old male patient who's following up with podiatry for his left foot. And here we have some images of this patient's left foot. And my question for you, for all of you, is what are the 5 basic densities in radiography? And I'd also like you to think about why they matter. You're going to get a chance to answer this question. And feel free just to think about it, and, feel free to take the risk. I'm just curious about everyone's thoughts. And you should all see a small box at the top of your screen with the option to answer questions. If you do not see it, please send a message in the chat. Great, so here we go. We see that most people mentioned that the 5 densities are metal, soft tissue, bone, fat, and air. A few people chose some of the other options, and this is great. We're going to discuss this. So before we begin discussing this, let's take a look at the images that are in front of us. So what we have on the left is a lateral view of this patient's foot. And on the right, we have an anterior to posterior AP view of the same foot. Now, as we're trying to assess what we're seeing, we're using 2 things: density differences and form, to help understand what we're seeing. Now, in radiography, there are 5 densities that we can clearly distinguish and delineate from each other. And they are characteristically broken down into metal, soft tissue, bone, fat, and air. And so the answer in this case is A, and let's discuss why. In this case, this patient had undergone amputation and happened to have the radiographs performed while he was wearing his prosthesis. And we know this because we can clearly see where there is dense bone. So radiographs will be what we call attenuated or blocked by higher density materials such as bone. And so as you can see here, bone is fairly bright. But we notice that the bone stops at the level of the amputation. And instead, what we see is density related to the composite of the patient's prosthesis, in which there are areas of trapped air. And because air is dark on radiographs, it's dark because x-rays pass through it, we can sort of distinguish the different densities and understand what we're looking at here. So distally, this patient's foot has been amputated. We're looking at the prosthesis. Proximally, we're looking at the patient's bone. Now, for comparison, the same patient on the same day had radiographs of the other side. So these are the radiographs of the patient's right foot. And we can clearly distinguish, again, the high density of bone from the intermediate density of soft tissues. We're going to talk a little bit more about some of the other densities that we can see in radiographs. But first, just a little bit of anatomy. So when we're looking at feet, when we divide the foot into the forefoot, the midfoot, and the hindfoot, the forefoot really refers to these bones, your metatarsals and your phalanges, which are separated from the midfoot by the Lisfranc joint, which is shown here. Proximal of the Lisfranc joint, we have our medial cuneiform, our intermediate cuneiform. Overlapping here are 2 bones, my lateral cuneiform and my cuboid. And here's my navicular. Proximal of those bones, we find our Chopart joint, proximal of which is the hindfoot. So in this case, in our amputation patient, we see that the forefoot is gone, and this patient is also missing most, but not all of the bones of the midfoot. The navicular is still there, okay, in terms of understanding a little bit of the anatomy. Now let's understand a little bit more about these densities that we see on radiographs. Air is going to be quite dark. And in fact, if you look at this radiograph, you can see that even the air around this patient's foot is quite dark. Next, not quite as dark as air, but darker than soft tissues will be fat. And we can see fat in this lateral radiograph. Here is the fat of Kager's fat pad, which is located anterior to the Achilles tendon. And we can distinguish this because fat is darker than the soft tissues, whereas the soft tissues are intermediate, as shown here by the Achilles tendon. And then we also see bone density here on this radiograph. Now let's talk a little bit about what we see on radiographs. There's a lot of information that's presented that's often not directly addressed. You often have a marker that will indicate which side is being imaged if there is laterality. So in this case, this L stands for left. You often have the initials of the technologist or some number indicating which technologist performed the study. And sometimes there's additional information, as in this case, where WT.B indicates that this is a weight-bearing study. So there's lots of information that's on a radiograph in addition to assessing the image directly. There's Kager's fat. Now, one of the questions, or one of the answer options, basically asked if you could distinguish blood from soft tissues. And the answer is, on radiographs, really and truly, nerves, as shown here. This is your sciatic nerve. Okay, we're at the level of the patient's hip. This is the proximal femur. Tendons, as shown here, these are the hamstrings, which are coming off of the ischial bone. Again, we're at the level of the pelvis in this case. Muscles, So again, this is still pelvic imaging. We're looking at the gluteus maximus muscle on the right here. And blood vessels, here are my femoral vessels. These all have the same density on radiographs. So these soft tissue structures or blood or a fluid-filled mass, the density on radiographs will be the same. And that is related to the fact that we cannot distinguish these soft tissue structures on radiographs. There is poor soft tissue contrast. Okay, so really the densities have to be very different from each other for us to be confident in calling them, which is why the classic ones are metal, fat, air, bone, and soft tissue. Now, contrast was an option, but a lot of contrast agents contain metals, and so they tend to be very, very, very bright. And so this is what I want you to remember. The 5 basic densities in radiography are metal, soft tissue, bone, fat, and air. Soft tissue structures, blood vessels, tendons, muscles, nerves, they're all going to have intermediate density. We use these density differences and form to make diagnoses on radiographs. Fantastic. Moving on. Our next case is going to highlight the importance of orthogonal projections. We have a 30-year-old male who had an accident, unfortunately, with a nail gun. Okay? And here's our question. Where is the nail? Here are radiographs. Where is the nail? Fantastic. So we had a couple of options. The nail is just at the palm of the hand, within the hand at the level of the metacarpals, or associated with a fracture. And we have a couple of different options, and we're going to go through and understand this a little bit better. Fantastic. Thank you. So what are we looking at here? So we are looking at lateral on the left, posterior to anterior in the center, and oblique radiographs of the, here's my L, left hand, and here's the number indicating the technologist who took these images. And here we can see the 5th density, which we did not directly address earlier, which is that of metal. Metal really attenuates X-ray photons. And so metallic objects on radiographs are going to be markedly dense. It comes as no surprise that this marker also contains metallic letters. And because we have multiple projections, we know that this patient's nail is actually within the hand, traversing from the palmar to the dorsal aspect at the level of the 4th and 5th metacarpals. These 3 projections allow us to say that we do not see an acute fracture here and allow us to confidently say that the nail is within the patient's hand. And so that may answer a question that some of you may have, which is, well, if this patient came into the emergency room, surely they can see that the nail is directly in the patient's hand, and that is correct. But they would not be able to answer the question of where is it? Has it fractured a bone? Is it extending into a joint? This is where we in musculoskeletal radiology comes in. So the answer in this case is that this patient's nail is located at the level of the metacarpals. It's within the patient's hand. We do not see an obvious fracture here. And having orthogonal projections, what does that mean? It means that we performed at least 2 views that are 90 degrees to each other. And we do this, especially in musculoskeletal imaging, because a single view may be misleading. If you think about it, if all we had was the posterior to anterior or PA view of the hand, you wouldn't know if this nail is located in the soft tissues of the palm, in the soft tissues dorsally, or if it's just lying on top of the patient's hand. So orthogonal imaging is really key for us in musculoskeletal radiology. And it can be helpful even in cases that are not as obvious clinically. So here we have a pediatric patient. We know that this patient is young because the physes are open. So I'm looking at my proximal phalanx here of the second digit, and I see that there's an open physis here and open physes in all of the bones. So we're dealing with a pediatric patient. And this patient, unfortunately, had a BB gun injury. So we do have 3 projections here. We have a PA view of the hand. We also have an oblique view that's really centered on that 4th finger, and a lateral view that's also centered on that 4th finger, but it includes the entire hand. We know that it's the left side because we have some of that left marker here. I did cut off some of that for the purposes of proper visualization of the images. But with these 3 views, we know that this BB injury here resulted in the bullet being lodged in the soft tissues at the palmar aspect of the 4th digit distally. Again, something that would not be possible to say with confidence without orthogonal projections. Here's yet another case. So this is another pediatric patient. We can see the open physes, who unfortunately was running and fell in his yard. And when he fell, his knee landed on top of a piece of wood that had some rusty nails sticking out of it. Now, on this single lateral view, we don't know if these nails are within the joint, within the bone, within the soft tissues. But with an additional projection, in this case, a sunrise view of the right knee, we can appreciate that one of the nails is within the soft tissues. The other may be intra-articular, okay? Which made a huge difference for this patient because the orthopedic team actually came and filled this patient's knee with a dye, a methylene blue dye. Then they removed the nails and looked to see if upon squeezing the patient's knee, any of that dye came out. If it did, they would have taken the patient to the operating room for a washout. In this case, it did not. And this patient ended up being sent home with a very strict schedule of antibiotics. So orthogonal projections are important in musculoskeletal radiography. I want you to remember that one view may be no view in musculoskeletal imaging. So here's our next topic. We're going to discuss the importance of high quality images. And here's my next question for you. Which option appropriately matches the quality issue with each image? Fantastic. So we have a variety of answers here. So let's get to the heart of this. Thank you very much. So going back to our image, we have image 1, an image of a right hip, and image 2, an image of a patient's right humerus. So one is a lower extremity, one is an upper extremity. And when we look at imaging of this patient's right hip, we have a really hard time looking at the hip joint itself because this patient has a large pannus, a large amount of abdominal soft tissue that's hanging over the hip joint. What this has resulted in is underpenetration. The X-ray photons have a harder time penetrating and giving us a good image. When you compare this to another case, you almost breathe a sigh of relief. Wow, we can actually see the hip joint in this case. So the answer is for image 1, we're struggling with underpenetration that's related to the patient's body habitus. For image 2, our right humerus as you follow this humerus down from the shoulder joint towards the elbow, things start to get a little bit blurry. The soft tissues start to disappear a little bit and the margins are not well seen. So this patient moved their arm during the study. And here we're dealing with motion artifact. If you compare this to a case without motion artifact, you can see how crisp our margins are. Okay. So one thing I want to point out, though, is even when the image is not of the highest quality, we are still responsible for careful review of the images in musculoskeletal imaging. So if we look at this study in which we cannot see the hip joint, what we do see in this patient are multiple sclerotic bone lesions. So this was a patient who has a history of metastatic prostate cancer, and we can see that and report on that. So what have we learned? We've learned that there are 5 basic densities in radiography. They are fat, air, metal, bone, and soft tissue. We've learned that one view may be no view in musculoskeletal imaging, and we've learned the importance of high-quality images. So we're going to practice this, and then we're going to end. We have 2 more questions. This patient's recent bullet injury is evidenced by what? That is my question for you. By what? Fantastic, everyone. So we do see that there are high-density bullet fragments, but actually there also is low-density gas. So let's take a look. So when we look at this patient's radiograph, the metal from the patient's bullet fragments really do stand out here. And you have to look very carefully, in this case, to appreciate the presence of soft tissue gas. That's at the entry point of this patient's injury. And so we have the arrows pointing out the metallic shrapnel or the bullet fragments, but we also have sort of dots and lines showing us where there is soft tissue gas in this case, if you look really carefully. Okay, so it can be a little bit tricky sometimes to distinguish some of the densities that are close to each other, such as fat and gas, but in this case, you use both the density and the form to help us. Here's our final question. This young patient has pain at the 4th proximal interphalangeal joint, which is right where this arrow is. What do you think about the quality of the images? All right, fantastic. We've got a lot of thinking going on here. So let's address these different answers. So respiratory motion artifact or breathing motion artifact is more of a problem with cardiothoracic imaging, where your breathing can really affect the quality of some images. In this case, we're not seeing the blurring of motion artifact from the patient just moving their hand. So that's not the answer here. We do have orthogonal imaging. We do have a PA, oblique, and lateral view of the digits. So that's not the problem here. The problem here is on the lateral view, there's overlapping right at the area of interest. And so in this case, to be sure that the patient didn't have a teeny tiny fracture hiding, we asked the technologist to kindly remove the other fingers from that area so that we can see the area of interest appropriately and be sure that the patient did not have a fracture. So this is another quality issue. Sometimes there's overlapping anatomy, and there are times when we can do something about it and other times when we cannot. Okay. So our bonus question, what is that foreign body? What is that foreign body? And to help everyone out, I'm going to circle the foreign body. And this, there's no question box that's going to come up for this one. This is just food for thought. This is imaging of a chest, but the bones are seen throughout the body. So we do see this patient's thoracic spine here. So in this case, this was a patient who was eating some chips and they accidentally picked up their AirPod and munched on that too. So this was an AirPod here. Okay. Thank you very much.
Thank you, Emma. That was great. Who's next up?
I think it's me. Okay, let's see. I know how to work one of these things. Share. Okay, this is working. New share, screen 3. You see a PowerPoint presentation?
It's working.
Looks great.
All right, great. So, all right, folks, buckle up. We're going to fly here through some upper extremity anatomy, predominantly using radiographs. I'm Naveed Faraji, assistant professor in University Hospitals Case Western Reserve. So let's see what we got. All right, so in general, we're going to review the radiographic anatomy of some of the upper extremity as much as we can get to in the next 15 or so minutes. And we're going to talk a little bit about the function and in addition to structure, and hopefully provide some clinical context. You know, as a med student, you can sometimes get stuck in the thought process that you need to just memorize things. And while there's definitely a component of memorization, I think if you have some context to what you're memorizing, it makes it a little bit easier. So we're going to try to provide some context. So let's just talk in general, emergency MSK radiology. What kind of exams do we see? I mean, there's obviously trauma and there's infection. Those are the main two broad categories of types of cases we may see. Trauma is a broad spectrum, peds versus adults, falls, child abuse, unfortunately, is a type of trauma that we may observe in pediatric musculoskeletal imaging. And predominantly, you can see for both of these x-rays, the best modality to start with, you know, so MRI is great, but it's not super sensitive to tiny osseous abnormalities. So radiography really is an amazing modality for that. And we love to read MRIs that have comparison radiographs so we can look for tiny avulsions. CT can be useful in the emergency setting because MRI is not always available. So if you're really concerned that there's a fracture but the x-rays are negative, CT may be of value. Or if there is a fracture and you want to further characterize that fracture as far as, you know, where it extends and the relative orientation of the fracture fragments, CT may be of value in that instance. And usually our orthopedic referrers like to have a CT prior to doing any surgical intervention. Again, for infection, X-ray is a great modality, but it's relatively insensitive to erosions. You know, so the bone is getting destroyed by this infectious process, and you need about like 50% of your bone mineral density to be lost for it to show up on X-ray. So X-ray is not super sensitive for osteomyelitis, so MRI would be valuable in that particular instance. Outpatient setting, we got arthritis, we got soft tissue and sports injuries that a lot of time can wait until the outpatient setting. Neoplasm, so MSK is cool, right? It's all sports and injuries and stuff that's fun, but there's also this, you know, this kind of tumor and cancer workup portion of musculoskeletal imaging, which is something that I find interesting. You know, so it's a diverse field, not solely based upon trauma and sports and things like that, but there's also a component of like neoplasm and cancer that goes along with it. And then pre-surgical planning, CT is a good modality for that, as we kind of alluded to. So let's get to the anatomy portion. So let's start with the shoulder girdle. As Amma kind of mentioned, that there's, you know, one view is no view, right? We like to have multiple views, and depending on if you're ordering examinations or in the emergency setting versus the outpatient setting, one might get different views of the shoulder. So this is a regular AP view we have here, and it's basically just like taking an X-ray-ish type thing, but moving it over to the shoulder. So the shoulder's in the center. And one thing to keep in mind is that the shoulder is not in the same plane as your chest, right? It's kind of your shoulder girdle, scapula is angled anteriorly, let's say 30 degrees or so. Don't quote me on that, but it's angled anteriorly. So if we really want a true orthogonal plane, thank you for teaching them that word so I don't have to explain it, Amma. But if you really want a true orthogonal plane of the shoulder, you need to get a Grashy view, which is this view right here, which essentially we are angling the X-ray tube such that it is, it's right down the barrel of the glenohumeral joint. So the way I describe this usually is like an AP. You see that there's like a Venn diagram type situation here, where there's overlap of the medial humeral head and the glenoid, where in contrast the Grashy, there is no overlap. So the Grashy is a really good view for looking at the margins of the joint. It's usually not this blurry, but sorry. You can look at the margins for osteophytes. What are osteophytes? They're little pointy projections at the margins of joints that suggest arthritis. So Grashy is a really good view for that, and that's what I like to use it for. In addition, we have these two views, right? So remember that X-rays, they're projection images, right? So if I'm looking here, I can tell you that the humerus is lateral to the glenoid and lateral to the chest. But I can't tell you if the humerus is anterior or posterior to the glenoid because I don't have a plane that tells me anterior to posterior orientation. I can tell what's medial, I can tell what's lateral. Similarly, the Grashy views, similar concept. And so that's where these two views can be really useful. So we have our scapular Y view, which is basically taking an X-ray like laterally of the shoulder, essentially, and it gives us AP orientation because we know this structure, the coracoid process, is an anterior structure of the scapula and the acromion is a posterior structure of the scapula. So now if I have a patient in the emergency room or outpatient and I'm worried about a dislocation, I need a view to give me an anterior to posterior orientation because as we know that most glenohumeral dislocations are anterior. There's always some posterior and there's other rarer ones too, but generally they're going to be mostly anterior, and in order to see if something's dislocated we need a projection that gives us that information. This is the axillary view, which is like taking a look up someone's armpit essentially. And again, we have our coracoid process, which is anterior, and our acromion process, which is posterior. We can see the humeral head is nicely seated within the glenoid, so there's no dislocation. Similarly here, the humeral head is right in the middle of our Y, so there's no dislocation. And we'll see cases of a dislocation here in a bit. So that's kind of, there's also internal rotation, external rotation, and sometimes that's like in the emergency protocol when we're just looking for fractures. And that's describes the orientation of the humerus, whether the arm is internally or externally rotated. So here's just a little bit of the anatomy, right? There's a lot of osseous structures here. We can see this is our lesser tubercle, which is where our subscapularis inserts. Here's our greater tubercle, which is where the other three cuff tendons inserts, supraspinatus, infraspinatus, teres minor. These are help to abduct the arm, okay, and then internal rotation as well for the subscap. So we have a coracoid process, a lot of tendons. So the point is, a musculoskeletal imager, we look at these x-rays, right? And we see all the osseous structures. But in our heads, what makes us good at reading x-rays is like we've read a bunch of MRIs. So we know the things that we cannot see that exist, which is all these muscles and tendons that are inserting in these areas. So relatively a lot of anatomy and musculoskeletal imaging, but once you do it enough times, you kind of get a grasp of it. So I think, being attuned to the MRIs and seeing the MRIs and seeing MRIs of a bunch of missed fractures kind of makes you a little bit more sensitive to finding those abnormalities when you look at the plain film. So for me, finding abnormalities on MRI is cool, but I feel like it's not, super challenging because you have a lot of more information. Is there bone marrow edema, things like that? But if I can find something subtle on an x-ray, that's really what gives me the gratification on a day-to-day basis. Although I'd still rather read MRIs, but that's a different discussion for another day. But so here's general anatomy of the shoulder. A lot of tendons and ligaments. So here's that scapular Y view. We kind of talked about this coracoid process, acromion process, acromioclavicular joint. And if I'm imagining where these muscles and tendons are, okay, so this is our scapula, this is our acromion, this is the spine. So above the spine is going to be the supraspinatus. Below the spine is going to be the infraspinatus. The subscapularis is the only one that's on the undersurface or the anterior surface of the scapula. So all of those have names that indicate their general location. And then the other one's the other one, essentially, which is teres minor, which is below the infraspinatus. So if you some of the names, thankfully, are not named after people that, don't make any sense. So, sometimes when you have anatomy that is named in an intuitive way, it's useful. So that's something to remember. So here is how you might see, this is how one might obtain an axillary view. When we kind of talked about this already, basically it's kind of like looking up someone's armpit. And so again, we know coracoid is anterior, acromion is posterior. And so also we know that the greater tuberosity is a posterior structure and the lesser tuberosity is an anterior structure. So if we're looking for fractures and we want to describe whether these fractures are extending to the greater or lesser tuberosities, it's important to know, which one is which and how they're oriented relative to the glenoid. We know that anterior glenoid fractures are common in setting of anterior glenohumeral dislocations. And so that's something we want to scrutinize in those particular cases. We're going to get to a case here. All right, here we go. So what is the abnormality in the following image based upon what we've discussed? And I'll let the question appear magically here. There it is. So what is the abnormality? These are the same patient, two separate images. Great. Lovely. So 64% of you are correct. This is an anterior glenohumeral dislocation. So one thing we can see is that the humeral head on the AP is superimposed upon the glenoid. And we know when the humerus dislocates anteriorly, it's not just plain anterior, it also dislocates a little bit medially and a little bit inferiorly. And you can see that here. So here's our coracoid process. Here's our spine of the scapula and acromion back here. And the humeral head is not in the middle of our Y, it's anteriorly positioned. So this would be an anterior glenohumeral dislocation. There are some osseous and soft tissue things that can occur in the setting of anterior glenohumeral dislocation. One I kind of alluded to is like a glenoid bony fracture, which is called the bony Bankart. You can imagine if you dislocate, the back of the humerus is hitting against the front of the glenoid as it tries to come back into position, normal anatomic position, but it isn't always able to do so easily, and you kind of have these osseous injuries. And then you can also have labral tearing because there's a labrum, a soft tissue structure of the glenoid. So we'll depict that here. So this is a patient CT that is in dislocation. This is a really extreme case. So here's our glenoid, and we can see our coracoid process right here. So I'm expecting to see a humeral head right here, right? It should be seated right in the middle of our glenoid, but we are going inferiorly now, and what we see is a humeral head that's shattered to a gazillion pieces. It's anteriorly positioned relative to the glenoid, and we can see the posterior aspect of the humeral head is abutting this anterior glenoid rim, and this kind of depicts why you get these kind of osseous injuries of the anterior glenoid and posterior humeral head from anterior glenohumeral dislocation. So again, a Hill-Sachs is the name we give to the posterior humeral head abnormality, and a bony Bankart is what we give to the glenoid osseous abnormality if there are fractures. I don't definitely see a Bankart in this case, but the humeral head, I mean, this is a really severe Hill-Sachs. I don't even think you would call it that at this point because it's like it's just a big comminuted fracture, which means that there are more than two fracture fragments. Okay. So here's another one, companion case, and here's our scapular Y view. And we can see, so this is not the most ideal position of the scapular Y view, and it's really difficult to see if this is fully dislocated relative to the glenoid or if it's just markedly subluxed posteriorly, because there is maybe some overlap still of the glenoid and the humerus here, but it's definitely not in the middle of our Y, and it's definitely posteriorly positioned. And here is what we call our light bulb sign, which is not going to make sense to you unless you look up, if we go back here to this regular AP radiograph of the humerus. So this doesn't look like a light bulb. You see the articular surface, you see the greater tuberosity and lesser tuberosity, and this while it doesn't look exactly like a light bulb, has a more light bulb shaped morphology because the humeral head is locked. And it's, God, I want to say internal rotation, but I don't want to be wrong. Can someone remind me internal rotation? Thank you. I see nods, so that's good. It's locked in internal rotation, which gives it this appearance. And you can still have bony injuries, and you may be hallucinating a little bit of mineralization here that could suggest an osseous fracture. Positive arrow sign. I'm going to go for just a few more minutes. I'm not going to try to get through everything, but so what is wrong with this patient? Positive measurement sign, I'll tell you. Yes, well done, folks. So acromioclavicular separation. So a decent portion of folks just thought it was a humerus fracture, and that's likely because this is a skeletally immature patient. We can see their proximal humeral physis or growth plate is open. It's not fused, so it makes it look like that there's a fracture here, but that's normal anatomy in a skeletally immature young patient. But we can see this positive measurement sign, which is suggesting that this corticoclavicular distance is abnormally elevated, and it's measuring 18. 14 is the number I use, 14 millimeters. And so I'm not a big fan of classifications, but the Rockwood classification is one that is useful, I think, because it helps us predict soft tissue abnormalities associated with an acromioclavicular separation. So if our corticoclavicular distance is elevated, we can then suspect that the corticoclavicular ligaments are torn, right? And this is, again, another instance where like we're not seeing the soft tissue manifestations. We see the osseous manifestations, which kind of helps us to suggest that there are associated soft tissue abnormalities. And in this case, it would be the corticoclavicular ligaments, of which there are two, the conoid and the trapezoid ligaments. And so, depending on the patient, this may require some intervention. And then grade 1 is normal, but clinically they have acromioclavicular symptoms, but there's no radiographic abnormality. Grade 2 is mild widening of the acromioclavicular joint, but no widening of corticoclavicular interval. 7 millimeters is the number I use. Contralateral radiographs can be useful to compare side to side. 4, I believe, is posterior clavicular positioning. I've never really seen any of these, to be honest. So this is really far superiorly displaced, and then this is inferior displacement. I've really only seen 1, 2, and 3, but I'm new to the game, still green here, so I'm trying to figure it out. But so yeah, we'll do another question. What is ailing this patient? Yeah, so fractures, if we want to look for fractures, I think one of the best things to do is just follow your cortices, right? So every bone has, not every bone, I guess most bones, yeah, they've got a central, more radiolucent part because they're essentially hollow tubes. And then they have a peripheral cortex, which provides the scaffolding or structure of the bone. So we want to follow the cortices and look for any areas of cortical irregularity that might suggest a fracture. And, most clavicular fractures are distal third, and we can see if we follow this. And again, so this is a fact to memorize, but these facts are useful because if I'm a radiologist, which I think I am, if I know where the most common fractures are, I can draw my attention to those areas first. I'm still looking everywhere, but it may save me time and it may allow me to be more sensitive to the more common abnormalities. And we can see right here, this cortex is disrupted from this cortex. There's this relatively linear lucency in an oblique fashion of the distal clavicle. So this is a non-displaced or minimally displaced distal clavicular fracture, which may be treated, conservatively, potentially based on its non-displaced appearance or minimally displaced appearance. But I'm not a surgeon, so you may want to ask a real surgeon, I guess, in this case, but that's what I would guess. So rather than power through, I think I'm going to just stop here. I appreciate everyone's attention. and I would be happy to present the rest of this on another day to anybody. So just let me know. And thank you again for joining us. You could have been doing anything at 7:47 Eastern Standard Time, but you are here with us in the SSR, and we all appreciate your time and attention. So I will hand it over to the next speaker.
Thank you, Naveed.
You.
All right,
Barry?
guys. Yep, I'm right here. I'm just get my screen shared here, get this teed up, get my presentation pulled up. You guys see that and hear me okay? All right, good to go. Excellent. All right, so again, my name's Barry. I'm one of the MSK guys here at OHSU out in Portland, Oregon. I'm going to fly through some kind of critical do not miss cases. I chose these cases because whether you go into radiology or not, you're certainly going to see this pathology, whether you're an ER physician, sports med, family, orthopedic surgeries. These cases all have some kind of common themes to tie in here. So here we go. Naveed did this already for me, so I'm going to skip the anatomy pieces and get right to the good stuff. So this is a 45-year-old male with ping pong injury here. And you can see here we have our kind of standard views, but something's funky here. What's that? The humeral head's not moving a whole lot here, right? This is supposed to be a Grashy view, internal rotation, external rotation. And things just kind of look fixed here. I have my scapular Y view here, and the coracoid process is anterior. So this is kind of funky looking, a little bit posterior, but not frankly dislocated. But I'm missing one absolutely critical view, and that is the axillary radiograph here. So now I find my coracoid process here. This is always anterior. I can see my humeral head impacted here on the posterior glenoid. So this is a posterior shoulder dislocation. And this is a critical do not miss case. So it's a rare one. Only 2 to 4% of posterior or dislocations are posterior, but it's important not to miss. The classic history, rare things like seizures or electrocution, so bilateral injuries, but in real life, really anything can do this. And this is the key point here. The axillary radiograph is absolutely critical to obtain to make this diagnosis. If the patient can't tolerate that view, you got to go to CT. Why? Because there's significant medical legal implications if this injury is missed, right? There's irreparable neurovascular damage to the rotator cuff and axillary nerve. So this is a do not miss injury. And surprisingly for our clinical colleagues, especially in bigger patients, it's a very difficult diagnosis to make as well. So just briefly here, here's that light bulb sign we touched on earlier. The humeral head's fixed in internal rotation. Here's that rim sign. Since the humeral head's posteriorly dislocated, there's kind of this pseudo widening. Here's that impaction fracture at 12 sign at the inferomedial humeral head. And then here again is that posterior dislocation on axillary radiography and our companion anterior case that Naveed showed earlier. Again, showing normal anatomy versus anterior dislocation, posterior dislocation, and inferior. So here's my first question. Which radiographic view is best for diagnosing a posterior shoulder dislocation? A, external rotation, B, Grashy, C, internal, D, scapular Y, or E, axillary? Excellent. So that's absolutely right. Axillary is critical. Scapular Y is helpful, but it can be misleading. So if you're not sure on initial imaging, you got to get that axillary view. Excellent work. Second, do not miss. 81-year-old female with left hip pain status post-fall. So I have a pelvic radiograph here as well as a close-up of that left hip here. And at first glance, I don't see a whole lot going on here, but I do realize that these bones are demineralized or osteopenic, and this patient can't bear weight. So we need further imaging to figure out what's going on. In this case, the clinicians ordered a CT, and you can see here there's this kind of subtle lucency at the femoral head neck junction. This is a non-displaced Garden type 1 subcapital femoral neck fracture. Does location matter here? Absolutely. As the fracture creeps up towards that femoral head neck junction, the femoral head's at increased risk for osteonecrosis or vascular injury, right? So this is a do not miss one. We see this more often in elderly folks, these subcapital fractures with low energy trauma. And the goal here really is to get the patient up and moving as soon as possible and minimize repeated surgical interventions. So thinking about these fractures, there's two main kind of groupings here with Garden. There's the type 1 and type 2. So incomplete, type 2 non-displaced, And then the second bucket is type 3 and type 4. So the key here is thinking about the vascularity here. The lateral epiphyseal artery is critical for femoral head blood supply. As things displace, the vascularity gets sheared off here, and now the femoral head's at increased risk of dying, right? So we want to really catch these before they displace. Radiographic, imaging wise, initial radiographs can often be occult or invisible. We're not going to see them well. So if the patient can't bear weight, we need to worry about what's going on here. Two main options of further imaging: CT versus MRI. CT is certainly faster, cheaper, and more accessible, but fractures can be CT called as well. So CT is great if you're questioning cortical irregularity. But if it's truly a cult on CT, or the radiographs are truly normal, MRI is by far the most sensitive way to go. And then thinking about management, right? So these type 1 and 2 fractures, you can throw a couple cannulated lag screws in, and the patient goes on their way. They're up and moving basically the next day. Once these displace like this, it's a bigger surgery. It's a hip replacement. And as you go from type 1 to type 4, the morbidity and mortality significantly increases. So here's our patient. It was caught in time. She was treated with cannulated lag screws, and she was up walking around the next day. Here's a companion case. This is a gentleman who fell down and couldn't bear weight. They came in initially. There was some kind of subtle irregularity at the femoral head neck junction, which was missed here. They came back a week later. Now it's displaced. We're no longer type 1 or type 2. Now this patient got a hip arthroplasty. Again, why does that matter? Longer rehab, the patient's down for a period of time, more likely to throw a PE. All kinds of bad things can happen. One more companion case here. Here's another patient with hip pain, cannot bear weight, right? So red flag. Initially, the radiographs are negative. They got a CT. The CT is negative. They moved on to MRI. So MRI 101 real quick here. T1 weighted imaging fluid is dark. T2 weighted imaging fluid is bright. So in this case, on T1, there's this dark line. This is a fracture plane. On T2, there's this dark line surrounding bone marrow edema. This is a fracture plane. This is a non-displaced femoral neck fracture. They were fixative lag screws and went on their way. So next question. Non-weight bearing radiographs of the hip are normal in a patient with suspected hip fracture. What is the next most appropriate exam to order? A, weight-bearing hip radiographs. B, follow-up radiographs in 7 to 10 days. C, CT of the pelvis with intravenous contrast. D, MRI, or E, no further imaging necessary. All righty, so I see some mixed answers here. The answer is going to be MRI. So CT of the pelvis with IV contrast. There's no reason to give IV contrast to look for a fracture. So this is a tricky question, but really the answer is going to be MRI. If you're going to go to CT, you would just do it without contrast, all right? Moving on to the next question here. Real brief here, foot and ankle anatomy. Two things to focus on. The first and second tarsal metatarsal joints. So here's the medial cuneiform, first metatarsal, second or intermediate cuneiform, and second metatarsal. That's the critical alignment for this case. This is a 25-year-old male with foot pain, stepped in a hole. And here we see some portable ER radiographs. And the key thing to notice here is the foot's kind of flopping in space, right? So these are non-weight bearing foot radiographs. And at first glance here, things look pretty good. I don't see a fracture. The alignment looks anatomic enough, but it's non-weight bearing. What we need here is weight bearing radiography to truly look at lower extremity alignment. Now you see this subtle step off here at the second tarsal metatarsal joint with lateral step off the second metatarsal base. This is a significant injury. This is a Liz Franck. We went on to CT, and often radiography underestimates the extent of fracturing. So now we have fracturing about the second and third tarsal metatarsal joints at CT. So this is our third do not miss injury. Why? Because the Liz Franck or second tarsal metatarsal joint is absolutely critical for midfoot and forefoot stability. These injuries can be kind of two main flavors, high impact and low impact. I'm focusing on low impact today because high impact is pretty straightforward. And this is, again, a do not miss injury, which can be a difficult diagnosis clinically as well. Why do we care about this one? If it's missed and the patient has lost to follow-up, they can develop a debilitating osteoarthrosis. This is a high litigation type injury, both for us as well as our referring clinicians. Briefly, the anatomy here. So the middle three metatarsal bases and short axis have this trapezoidal morphology. Here's that second metatarsal. This is critical. It functions as that kind of keystone in a classic Rowan arch, which is key for stability and recessed between the medial and lateral cuneiforms there. As far as the mechanism goes, the forefoot is abducted and rotated here with the hind foot flexed, and then this compressive force, either axial or rotational along the plantar flex foot, causes this kind of lower grade or lower velocity Lisfranc type injury. From an imaging perspective, non-weight bearing radiographs are often non-diagnostic. If you see a fleck-like avulsion fracture subjacent to the second metatarsal base or medial cuneiform, that's essentially pathognomonic or diagnostic. But if negative and clinical suspicion persists, you got to go to radiography weight bearing. If they really can't bear weight, you got to go to CT because 50% are normal initially. As far as weight bearing radiography goes, your key really is focusing on that second tarsal metatarsal alignment. Here's non-weight bearing, here's weight bearing. In this case, you can see it's normal at non-weight bearing. With weight bearing, there's that lateral step up. That's a significant but very subtle injury. This radiologist went to jail. This radiologist made it out because they got the weight bearing radiographs. All right. So you got to be careful of this injury as well. When do you go to CT? A couple times you go to CT. One of the radiographs are occult, but you're very suspicious, you can go to CT. The other times to characterize that diffuse tarsal metatarsal fracturing. Here's that flex sign subjacent to the base of the second metatarsal. You go to CT, there's multiple additional fractures about the tarsal metatarsal joints. MRI is good for truly normal radiographs and CTs to look for purely ligamentous injury. Treatment-wise, if it's non-displaced at the second tarsal metatarsal joint on conservative radiography or on stress radiographs, you can either do conservative or you can do operative treatment. So when it comes to fracture dislocations, surgery is the way to go. When thinking about these injuries, the goal really is anatomic alignment, right? So you can see here, this is the fusion of the first through third tarsal metatarsal joints with fixation of the Lisfranc interval. Again, if you don't get to that point, if the injury is missed, you get this debilitating osteoarthrosis at the midfoot. So my third question is, what is the most sensitive radiographic finding in diagnosing a Lisfranc injury? A, lateral step off at the second tarsal metatarsal joint greater than 2 millimeters. B, dorsal forefoot soft tissue swelling. C, lateral step off the third tarsal metatarsal joint. D, pes planus or flat foot deformity. Or finally, E, widening between the proximal second and third metatarsal shafts greater than 2 millimeters. All right, so good. Most of you guys got that step up at the second tarsal metatarsal joint. That's critical. That's the main diagnosis. They're excellent. And last but not least, a little bit of wrist here. So the key anatomy and wrist radiography here, the scaphoid bone, the proximal carpal row, the lunate here, and then the scaphoid here on the lateral projection. So this is a 36-year-old male with a history of fall and snuff box tenderness. And you can see at radiography, not a whole lot is going on here again. So frontal view, oblique view, lateral view, essentially negative. However, they had significant clinical suspicion, right? So they went on to an MRI in this case. Again, on T2 weighted imaging, fluid is bright. So there's this dark fracture plane on T2, dark on T1 where fluid is dark. This is a non-displaced scaphoid waist fracture, or fourth and final, do not miss injury. So up to 80% of carpal bone fractures are at the scaphoid, more often seen in younger folks. Typically, the mechanism is a fall on an outstretched hand or fouche injury with snuff box tenderness, right? So here's the snuff box between the first and second compartments of the extensor tendons. Most often at the scaphoid waist, and up to 20% are occult or invisible at initial radiographs. Imaging-wise, if the radiographs are negative, you got to repeat these in 10 to 14 days or consider cross-sectional imaging. Again, CT is good if you're questioning cortical irregularity, but they can be CT invisible as well. Again, MRI is the most sensitive examination. You see these fractures almost immediately. Why do we care about these? If these are missed, the scaphoid can die and you get non-union advanced collapse, which we'll talk about in a second here. So the key finding here is thinking about the scaphoid blood supply, right? The scaphoid blood supply from the radial artery is recurrent, meaning it comes from distal to proximal. So the closer you fracture to that proximal pole here, the more likely the fractures to undergo non-union or not heal with potential bone death because you're severing that blood supply. If there's less than 1 millimeter of displacement, the vast majority will heal. Here's the dreaded complications. First off, osteonecrosis of the proximal pole of the scaphoid here. So marked increased radio density and the collapse has begun. The fracture lucency remains distinct. As time goes on, the scaphoid further dies in fragments and you have scaphoid non-union advanced collapse or a snack wrist, right? And this is where the osteoarthritis really starts cracking here. You get capital lunate, severe osteoarthrosis, radial scaphoid joint. During this process, you get this humpback deformity in which you get volar or palmar angulation of the distal and proximal poles and this palpable dorsal abnormality, which is a precursor to collapse. Ideally, again, more than 1 millimeter displacement. These are fixated with a surgical screw, and here's a nice outcome. So my fourth and final question, which type of scaphoid fracture is at greatest risk for bone death or osteonecrosis? A, scaphoid tubercle fracture, B, proximal pole fracture with greater than 1 millimeter displacement, C, non-displaced distal pole fracture, D, non-displaced proximal pole fracture, or E, dorsal avulsion fracture. Alrighty, good. That's absolutely right. So that proximal pole, that blood supply is at risk, it's displaced. That's the one that's not going to heal. Very good. So last but not least, guys, a couple take-home points. One, posterior shoulder dislocation. If you got to get an axillary view to make sure it's not posterior dislocated. If the patient can't tolerate it, you have to go to CT. Why? Because there's significant neurovascular morbidity if missed, and this is a tough diagnosis clinically. Garden type 1 femoral neck fracture. The radiographs are often normal. If there's strong suspicion, go to cross-sectional imaging, including MRI. If missed and that fracture displaces, it becomes a much bigger surgery, which is much more morbid with increasing mortality. Number 3, Lisfranc type injury. Do not stop at non-weight-bearing radiography. Weight-bearing radiographs are critical. Why do we care about this? Because if we miss it, the midfoot can collapse and die with debilitating osteoarthritis. And finally, the non-displaced scaphoid waist fracture. Often occult or invisible at initial imaging. Consider repeat radiographs in 10 to 14 days or cross-sectional. If you miss this one, you can get that snack wrist morphology and, again, horrible osteoarthrosis. So I really appreciate your attention, guys. Thank you very much.
So can you all see this, the first slide? Yep, you're good. Thumbs up. Awesome. So a little bit of a change in pace. I'm going to concentrate on one thing. So you're going to have a little master class in the hamstring muscle group and tendons. So I'm going to focus this talk on the avulsion injuries of the hamstring unit. All right, so short introduction is going to be with some teaching points here. So through this presentation, I hope that you'll be a little bit more familiar with the anatomy, the function, biodynamics of the hamstring complex, which consists of 3 muscles, the biceps femoris, semitendinosus, and semimembranosus. Recognize the types of avulsion injury patterns, and evaluate the imaging methods utilized to diagnose these hamstring lesions. All right, so we're going to start with the anatomy. So the hamstring muscle complex, as I mentioned, is composed of 3 muscles. The biceps femoris contains 2 heads. It has the long head and a short head. Easy. Long head originates from the ischial tuberosity and traverses 2 joints, the hip joint and the knee joint, whereas the short head origin arises from the femur itself, so it only traverses the knee joint. Then you have the, oh, there we go, perfect. Then we have the semitendinosus. This muscle also originates on the ischial tuberosity and traverses 2 joints. And then we have the semimembranosus that originates on the ischial tuberosity. Now, the biceps femoris and the semitendinosus arise from a conjoined tendon, and the semimembranosus gets its own insertion all by itself. The biceps femoris inserts laterally on the fibula, whereas the semimembranosus and tendinosus insert on the medial aspect of the proximal tibia. All right, whoops, a little bit too fast there. So this is an image pilfered from the internet. So I give credit to the Rad source internet, which had a really nice workup on imaging of the hamstring muscle group and tendons. So I'm just going to go over what these images are. These are coronal images through the posterior aspect of the thigh. So we have the hip joint up here and the knee joint down here. So this red arrow on this image right here, which is a little bit more posterior, so this is more anterior. This is the conjoined tendon of the biceps femoris and the semitendinosus. This is the singular tendon of the semimembranosus, marked in blue, with the blue muscle down here. And this is located a little bit more anterior to this. All right, so this is an axial image at the level of the ischial tuberosity, which is marked by this little triangle right here. So we have the lesser trochanter, the lesser trochanter of the femur here. And then we have the structures of the complex of the hamstring tendon group here. So they insert on the ischial tuberosity. The blue is the semimembranosus. It hogs it up. It has big insertion onto itself. And then the twins, or the semitendinosus and the biceps femoris, have a conjoined tendon insertion that's located a little bit more medially. What's circled in yellow is the sciatic nerve. So it is quite close to the tendons of the hamstring complex. So as you can imagine, any pathology of those tendons, such as tendinopathy, inflammation of the tendon, tenosynovitis, avulsion injury, tearing, can cause hemorrhage, edema, and effacement of the fat surrounding that sciatic nerve, and can cause impingement of the sciatic nerve and lead to sciatica and pain for the patient. That's that little triangle of happiness right there by the ischial tuberosity, which I need to stop pressing the button so fast. All right, there we go. So I have my little Santa Claus here. He's all in blue because Ohio State didn't win, didn't make it to the playoffs. But anyway, he's all in blue right here. Little hat right here, the ischial tuberosity. We have the physis right here. When the patient's skeletal mature, this should be all one unit. Then we have the semimembranosus tendon and the conjoint tendon. So again, this is going to be more medial, more lateral. And then we have the sciatic nerve right here, with a little beard right here. And this is what it looks like on the MRI image when I have the labels here. So IT stands for ischial tuberosity, semimembranosus, conjoint, and sciatic nerve. And then we have the femur right here with the lesser trochanter. So now I mentioned before that there are two heads of the biceps femoris. The short head of the biceps femoris has its origin on the femur on the linea aspera, the posterior aspect of the femur. All right. The semimembranosus, since it's hogging up its own insertion, can be up to twice the diameter of the conjoint tendon, and that will be normal, and that's appreciated better on the coronal images I'll show next. So the function of the biceps muscle complex is a very powerful muscle of the thigh. It will help to extend the hip, flex the knee, and it's also in that position where a lot of the injuries to the complex, particularly proximally, will occur when your leg is in that position. Most of the injuries most of the injury to the hamstring muscles are secondary to muscle strains or tendon avulsions. Well, what else is there? Direct trauma or direct contact, which is quite rare. So even if you do get direct trauma, they don't, it is rare, but they don't tend to tear them or cause much injury unless you're getting hit with a football helmet coming at you about 50 miles an hour. So imaging can significantly supplement the clinical evaluation and aid in directing the treatment of this injury. Why? Well, if you have an avulsion injury associated with a bony fragment, you can see it on radiographs, and you can see how much that bony fragment is retracted. But not all avulsion injuries contain bony fragments. So MRI imaging will help detect if the tendon is actually torn, and if so, how much of an avulsion or how far the distance is from the torn or retracted tendon from its home base at the ischial tuberosity. Also, imaging can evaluate the pattern of edema within the muscle. So this is a muscle strain right here, and it has this nice feathery pattern that's often seen with a bipennate muscle, which is a muscle bipennate, like a feather. You have the tendon centrally located within the muscle, and then you have the feathery margins on either side of it. So just little feathery edema. This is a grade 1 muscle strain. I didn't really talk too much about the grades of muscle strain, more about the avulsion injuries, but grading the volume of edema in the muscle and the pattern of edema in the muscle, that fluid signal, can guide the radiologist to help the orthopedic surgeon tell them how soon the patient can go back to play or return to playtime. All right. Mechanism of injury of hamstrings. So as I mentioned, these hamstring muscles traverse 2 joints, and because of that, they are more susceptible to injury. Muscles that act eccentrically. So these hamstring muscles can act eccentrically and concentrically. So eccentrically, muscles that contract that way eccentrically cross two joints and contain a large proportion of the type 2 fast twitch fibers are at greatest risk for injury. So this is just setting these guys up for injury. Injury to the muscle or the muscular tendinous junction, MTJ, usually typically occur during eccentric contraction. And that is during sports such as football, track, soccer, anytime that you basically have rapid acceleration, like sprinting. So, and I'll go over what eccentric means in a second. This eccentric type injury can also cause avulsion injury, which is a tear at its origin approximately. Avulsion injury may also be the result of passive stretching or stretching activity to the hamstrings, usually the semitendinosus, although this is a little bit less common. Sports that can cause forceful stretching and very forceful, fast action of stretching the muscles, such as water skiing. And if you ice skate like me, ice skating, and running hurdles can also cause tears of the avulsion injuries of the biceps. So a little video here, make sure my volume's turned off. Yep. So right here, we're gonna, right there, this goes the hamstring. So pattern of hamstring injury. So we have the eccentric contraction. So this might seem a little oxymoron here, but the hamstrings lengthen. In eccentric contraction, the hamstrings lengthen as they contract eccentrically. So this acts to slow down the leg, and it occurs in preparation for the foot to hit the ground or the foot strike, and it occurs in the terminal swing phase of the person's gait. So the leg is extended, if it's extended, and the knee is going to be slightly flexed to extend it. And as they're doing that, the muscle tightens, but it's lengthened, and then that force of the foot coming down can cause a tear. In concentric contraction, the muscle shortens, the hip is extended, and the knee is flexed. The hamstrings contract, and as the foot pushes off the ground, as a takeoff phase of the gait, and it's at this phase of the gait, the hamstring can snap. Now, honestly, there might be a question at the end. What's the difference between the two? But I'm really not that mean. I think the point of this really is at any point of the gait, when you're putting stress on that hamstring tendon, it can snap. And here we go here. So a little bit of a different diagram here. Hamstring muscles contract eccentrically. So when the muscle is lengthened and the force is applied across that muscle, it's contracted, but it's lengthening. And in this case, the toes are pushing off. So as it's lengthened and you're just starting to reach down to toe off, you have the load, and then when the toe pushes off the ground, you have the extra load and the force and the forward momentum that puts more of a strain on the hamstring tendons, and they are prone to tear if not properly conditioned. Hurdling is a very common, well-known source of hamstring tendon, often with avulsion, and especially in adolescent before they're skeletal mature, when you have the apophysis at the ischial tuberosity, is this kind of force with the lengthening of the muscle, contraction of the muscle, and pulling at its attachment to the ischial tuberosity. Very common. And then again, when we're having the concentric contraction here with the hip flexed, extended and the knee flexed, you can also get the pulling and the tightening of the muscle here. All right, so it's really pretty often in an acute setting of hamstring tendon, it's pretty obvious acute onset of pain during the rapid acceleration or stretching of the thigh, often accompanied with an audible pop and ecchymosis, swelling, pain, screaming, rolling on the ground. Oftentimes a palpable defect may be felt depending on how far the tendon is retracted and the degree of injury. There's pain with passive extension of the knee with the hip flex at 90 degrees if they let you do that, but that's something that we'll let the orthopedic surgeons do and get yelled at as they do that. I will be very happy just to look at the images to let them know how much is torn. So the sciatic nerve being so close to those tendons, you can imagine, even if the tendons don't involve a bone fragment, just by getting retracted and pulled away with that hemorrhage and fluid, it can cause entrapment or inflammation of the sciatic nerve and sciatic neuropathy. The impairment caused by an injury to the biceps tendon can range, and depending on the number of tendons torn, or if they're torn, and the degree to which the distance from which it is torn from its origin. All right, so imaging, MRI is the most reliable imaging modality in order to evaluate the full picture. You can use ultrasound, you put a probe on it, but in order to get the forest for the trees, MRI imaging is the best modality. You're going to get the entire thigh. You're going to be able to see how much retraction there is, evaluate if there's any hemorrhage or edema, fluid buildup, and associated muscle strain. What MRI is not great at is evaluating small flexed bone that may be associated with a bony avulsion. That we leave for the CT or the radiographs. Bone is very difficult to see on the MRI examination because of its signal intensity. So avulsion injuries are a lot more common with the skeletally mature or the adolescents, as I mentioned, because of that apophysis, which is just due to the tendon insertion on the ischial tuberosity. So that apophysis is a lot weaker than the tendon insertion on the bone. So the weak part's going to break, and there you go. If there is less than 2 centimeters of distraction of the tendon or the bone, usually are treated conservatively. These are evaluated on a base per base, and of course, high-end athletes are going to go to surgery a lot faster than I will. So cortical avulsions can be, as I mentioned, be very difficult, if not impossible, to discern on the MRI examination, and the plain films are important in the evaluation of this pattern injury. Even this, so that's why I put this arrow here, so you can see the tiny little bone fragment adjacent to the apophysis on that right side. It can be really difficult, especially in the acute setting, because sometimes it's just a little cortex. It's a very thin sliver of bone. But you know, this is a patient who is skeletally mature. There's no physeal opening. We don't see any physis up here, which is usually the last one to fuse. So this is a skeletally mature patient, and we have that little kind of cortex. If this were a kiddo, it would be a lot bigger, a lot easier to see. Now, what happens to this? This grows. We are not starfish. This grows because of about 4 to 6 weeks after it's sitting there with the hemorrhage and inflammation around the bone. You can get what's called heterotopic bone formation, new bone formation, callus formation, and eventually that can ossify. And it can look like this big hairy mess, ossified mess at this location, and it can look very aggressive. So knowing that the patient had an injury at one point in time, and you see this ossification here later on, which I'll show you some images, it's important to know, like, oh, don't worry, that's not anything really to worry about. That is just a growing bone fragment that might have to come out later on from the avulsion injury. All right, and so pulled for it from the internet. Again, we can't remember the site though, but here we have the radiograph. 3-dimensional CT, cross-sectional CT. So we can see these nice, this is a patient who is skeletally mature. We see those open physes here at the iliac crest, and we have this nice avulsion injury of the apophysis. Here we go, nice apophyseal injury, and then part of it here on this one single axial image in the axial plane. And then here's the MRI. So this fluid, we know that there's a tear. Here's the fluid, here's the tear of the tendon, and there's marrow edema like seen on the rest of the ischial tuberosity, and this little rim in this one plane. We'll have to go into different planes to see if there's bone, but it can be really difficult to tell what is bone and what is muscle here. So the differentiation of the two materials is a lot more difficult to make on the MRI, so much easier to see on radiographs and CT. So what are avulsion injuries? What am I going on about, right? So avulsion injuries defined as pulling away of one structure from its attachment to another structure. And this is usually tendon and ligament to the bone attachment. So you can have with avulsion injury, which is a wide definition, you can just have the tendon or ligament torn without bone involvement. Bony fracture, avulsion fracture, is when that bone is associated with it and pulled up. So here I have all these arrows pointing to, we should have fat density, which was described wonderfully in the first talk. So we have the different densities on the radiograph here. We have the soft tissue density, and this is Kager's fat. This should be fat density, and there's so much edema here. That's what these little arrows, like someone's shooting them, little arrows showing the soft tissue densities here. We should see this. There's too much soft tissue swelling, suspicious, again, in conjunction with the physical examination, is an absence or tear of this Achilles tendon. Don't see a distracted bone fragment. Sometimes you can. You can get an avulsion fracture of the Achilles tendon from the calcaneus. Go on to the, and we can get an MRI, and that shows this tendon. Some of it's torn here, some of it's torn here, but the Achilles tendon tear and fluid and edema and a lot of badness. Here's marrow edema-like signal with the calcaneus. Cortex is intact. Don't see a displaced fracture of the calcaneus on this one single sagittal image, but can see avulsion injuries, but they're a lot harder to diagnose on the radiographs. And what am I talking about? Here's a finger. This is not the hamstring, but this is an avulsion fracture. And this is a avulsion fracture, the volar aspect of the terminal phalanx of the finger. And here's that little bony fragment from the attachment of the terminal flexor tendon. This pulls off, and this needs to. The bigger the size of this fracture, more likely this patient's going to go to surgery. Right here. So you can see avulsion fractures in all parts of the body when you have where you have tendon and ligament attachment. So let's get back to the hamstring. So here's a skeletally immature patient. We have the open physis at the iliac crest. You can tell that. And just following the pattern that I'm looking for, the ilioischial line, iliopectineal line, symphysis pubis, here. So this patient had some right hip pain, and we had an avulsion fracture of this apophysis of the right ischial tuberosity. There we go, zoomed in, that is right there. Voila. All right, here's a little bony model. So we can have not just the hamstring, but we can have some other things avulsed from the pelvis. So just briefly, I'm just going to show this to you to know that you can diagnose what's going on radiographically if you have these apophyseal fractures that are displaced from the pelvis, such as the sartorius at the anterior superior iliac spine and the rectus femoris at the anterior inferior iliac spine, as well as the hamstring tendons. All right, skeletally immature patient, right? We have the open physis here at the iliac crest, and voila, we have this. So I put the dates on this one. So his injury was around this time, a 12-year-old kid, just minding his own business, running across the yard. So we have this avulsion injury of the ischial tubular apophysis here, and we can see that looked very much like the other one we had, kind of a small sliver, but it's growing. So now, just a few months, 14. So we have this, it's distracted a little bit more, but we have more ossification along this site. Here, wait, there's more, as they say. Now we going into July, just a few more months, and it's becoming more ossified. We're getting more ossified matrix, it's getting bigger. And now this could be a problem because now we have this big freaking rock that's sitting in, down around the ischial tuberosities. And you're sitting on this. This can be very painful. And as you're sitting, this can get displaced and it can impinge on the sciatic nerve. There we go. So zoomed in a little bit to help that this callus formation is maturing. When we say maturing, it means it's turning into bone. It's laying down the bone matrix down here. And it's, you can see a lot more mineralization and ossification in the soft tissues. All right, here's another 12-year-old who had an injury just by running across the field. And this one's a little bit more difficult. So this patient had sudden onset of right hip pain. It's really difficult to see any kind of bony avulsion and should see something going on. This patient is still skeletally immature. Don't see a whole lot. I could probably hallucinate some. So let's go to CT. Oh, wait, there's some bone right there. There's a little bit of soft tissue swelling. Let's get another plane. Oh, let's get the arrow out. Another plane. We have an axial image, and this is another axial image, a little bit more distal, about 2 or 3 centimeters distal to this one. And so we have the ischial tuberosities, and we have this tiny little fleck. I cut it off on this one, but one thing that's very subtle is the difference in the soft tissue density or the soft tissue edema and the effacement of the fat planes and the distribution, we would expect to see the hamstring tendons. And then we go to MR. The MRI, this is incredible because it didn't look that bad on the CT, tiny little bone flex, but when we go to MRI, and this is the beauty of it, we really have an idea of what really is going on. This kid's not a complainer. This kid has a serious injury. There is so much fluid right here. This is crazy. So we have the semimembranosus, we have the conjoint tendon here, and they are displaced laterally. Where the heck is that sciatic nerve? I don't know. It's being smushed. And then here on the coronal images, nice, normal semimembranosus hogging up its own insertion. And then we have part of the conjoint tendon down here. We can see it just not in this plane, but this whole unit, everything is just torn. So that semimembranosus, that conjoint tendon, it's just toast, as I like to say. It's toast, and this patient needs to go to surgery. Yeah, bigger picture. All right, so here's a patient who had a remote injury, but now she's complaining of pain when she sits down. She's having point tenderness over her right ischial tuberosity. And I should say that these patients are probably all right-handed, right? So right side, right ischial tuberosity, and we can see this more mature bone right here. So this isn't a fleck. We have, it's really well defined, and it has some cortex around it. So this is a sign that this is not acute. This is a remote injury because this is mature bone with cortex and zoom power right there. So you can see that nice, well-defined cortex adjacent to the ischial tuberosity here. She's having pain. We know that she's, this is a sign that she had a hamstring injury in the past, but she's still having pain. So what's going on? Let's go to MR. MR, it doesn't show bone very well, but it will show bony deformities. And this is part of the ischial tuberosity, but it doesn't form that nice little triangle or Santa Claus hat that the other one had in the other diagram. We have this bony projection here. It is all disorganized. This is crazy. So we have the hamstring complex here. It's really disorganized. It's not really where it needs to be. The other side looks nice and smooth. This looks pretty bad. So here is that semimembranosus. Here is the conjoint tendon here. Both of them look a little disorganized, especially this bone fragment is attached, is just due to the semimembranosus here, but there's pathology on both sides. So she's going to go to surgery. Zoom in. There we go. You can see a little bit better now. And there, this is one without fat sat. So this little blue line popped up for a reason. So this is the deformity right here, semimembranosus. Nice. Look how much space there is between the ischial tuberosity and the femur, particularly the lesser trochanter. This space is narrowed. What happens when this patient internally and externally rotates that hip, this is going to clunk up and get too close to this bony projection now. You're losing a lot of space here. So you're going to get some ischiofemoral impingement. So with repetitive rotation of this hip, you're going to get impingement in this space. It is going to affect the muscles in this space, particularly the quadratus muscle here. You can get edema, and already the sciatic nerve is like, I am way too close to that angry looking bone right here. You're going to get edema. You're going to get further impingement of the sciatic. So something needs to be done about this. And that something is, this guy got to go. And that's what they do. So she had repair. She went to surgery. She had that bone taken off. She had the tendon reattached back on, and it was partially torn. And even the conjoint tendon was partially torn. So everything was repaired and sealed up really nicely. And there it goes. Ugly before. This is the surgery. There's that bone fragment, and it's gone. Nice. And everyone likes it before and after. Before. Oh, come on, man. And after. Yay. So there's a little bit of mineralization there, but that thing's gone. Hamstring tendons are fixed. Sciatic nerve is happy, and everyone's happy. Here's another patient, skeletally immature. We have this old avulsion fracture of the apophysis here. And there we go. MR was a complete tear, not acute, complete tear. avulsion of the apophysis. And we have this scar right here with the hamstring tendon torn. Still has some pain, but they let that patient heal up a little bit more. That patient did not go to surgery. So you can have a complete avulsion. You can have complete avulsion, which means tear of both the conjoint tendon and the semimembranosus, or you can have tear of just the conjoint tendon. Now, if you're going to have a tear of just one, it is usually going to be the biceps femoris or the conjoint tendon complex. Usually the semimembranosus, when you have the eccentric or concentric, the semimembranosus likes to hang on, and it does hang on more than the conjoint tendon when you have passive stretching. So if you're having something, if you're going in for a Thai massage, let's say, which if you watch The Amazing Race looks really painful, they stretch you in all these different positions. If they stretch this, then that might be within one rare time that you're going to get just the isolated semimembranosus tendon tear. But this guy's hanging on for dear life. This one, the conjoint is torn, it's toast. Complete tear or near complete tear of both the semimembranosus and the conjoint tendon, and we have fluid collection or hemorrhage right here that is going to impinge. It is lateral. It's going to impinge on the sciatic nerve. And here we go again. The tendons can avulse without bony avulsions. That's why MRI is so great, such a great tool, because we can see that tendon tear. We can see any hemorrhage or fluid collections between the torn tendons and the bone, and any mass here. Sciatic nerve looks really scared. He's backing away. Can impinge on that sciatic nerve. MRI is going to tell us the extent of the damage, what's going on, and if there's anything else that we need to address. So, and this is the actual image. This is a coronal image through the hip joint. We have the ischial tuberosity, and a lot of fluid right here. So retraction of the tendon. So this is the beauty of MRI. We can see within the additional images, look to see where the margins of the tendon are. We can tell the surgeon, okay, listen, this is retracted X number of centimeters with insertion. The quality of the tendon looks good or bad. So they know for surgical planning what they need to do, what kind of approach, what kind of repair, do they need a graft. So another complication, chronic hematomas, excessive callus formation, displaced bone, all these things can lead to compression neuropathy of the sciatic nerve. Here's an MRI. Bone's not great on MRI, but this is a T1 weighted sequence. There's no fat sat. Bone is bright, fat's brighter, muscle is dark, and then this little geographic thing right here looks like bone, but it's kind of weird. This is an avulsed fracture with heterotopic bone formation in the region of the sciatic nerve causing compression. Seen best on, you can see it on radiograph, you can see it better on MR, and they're a lot more fun to read. So in conclusion, hamstring injuries are not uncommon, double negative there, but they're not uncommon, especially in the adolescent population, because they have those apophyses that are weak and they like to get torn off. It can be diagnosed on radiographs. If there's bony avulsion or apophyseal avulsion, which is great, one and done. But usually we go to MRI to see if there's anything else going on, the extent of muscle edema, the extent of muscle injury, anything else, any hematoma in there, or any other badness we're going to see on MR. And that is all I have. So thank you so much for your attention. Oh, I have questions. I do have questions. They were at the end of it. And I think I have to go out and let me get my, oh, that's magic. Thank you. Okay, first question. This is like a kind of a test to see if you're paying attention. What muscles make up the hamstring complex? Number one, biceps femoris, semimembranosus, and I have to move this thing. Oop, gluteus minimus. 2, semimembranosus, biceps femoris, iliopsoas. 3, semitendinosus, biceps femoris, semimembranosus. Or 4, gluteus medius, semimembranosus, semitendinosus. And survey says, all right, survey says semitendinosus, biceps femoris, and semimembranosus. You all are awesome. So great job. And that is correct. Woo. What nerve can be affected after hamstring complex injury? Peroneal, sciatic, posterior tibial, or sural? Again, we're looking for the nerve that can be affected after hamstring complex injury. I always wanted to be Alex Trebek. So, all right. And the answer is awesome. Sciatic nerve. That sciatic nerve is the one that is right there next to the origin of the hamstring complex on the ischial tuberosity, and it can get in the way. All right. Which is true regarding apophyseal avulsion injuries associated with hamstring complex injury? Okay. Common in adolescent hamstring injury, can cause impingement on the sciatic nerve if displaced, are easily seen radiographically, or all of the above. And all of the above. Awesome. Very good. So, and with that, I will conclude my presentation. I think that's it. Yeah, I think that was my last question. So again, thank you so much for your attention.